mode until the question and answer session of today's call. At that time, if you would like to ask a question, please press star 1. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the meeting over to Susan Hayashi. You may begin.
Thank you. Welcome, everyone. This is the second webinar as part of the HRSA MCHB 21st Century Cures Act Evaluation Capacity Building webinar series. And the focus of this webinar is on program branding for promotion and evaluation. I'm going to turn it over to Lauren Ramos, the Director of the Division of MCH Workforce Development. Lauren?
Great, thank you, Susan, and good afternoon, everyone. Thank you so much for joining this second Evaluation Capacity Building webinar for the HRSA Pediatric Mental Health Care Access and the Screening and Treatment for Maternal Depression and Related Behavioral Disorders programs. We'd also like to thank you for all of the data collection efforts thus far and for submitting your data. We know that's a lot of work, but we appreciate it, and we will definitely be reviewing it and using it going forward. Today we will discuss how program branding can facilitate program recognition, future data collection activities, and evaluation. We're fortunate to have two awardees speak about their current processes for program branding, the Missouri Pediatric Mental Health Care Access Program and the Kansas Maternal Depression Screening Program. So on behalf of all of MCHB, we look forward to hearing your presentations and to all of the comments and discussion in the question and answer session to follow. I'll now turn it back to Susan to provide some brief housekeeping information. Thank you.
Thank you, Lauren. And good afternoon again, everyone. For those of you who don't know, I am the project director for the HRSA MCHB evaluation contract, and it's been really a pleasure to speak with you and work with you over these months that we've been working together. And for this particular one, this is our second webinar, as we've said, and for this project year, there will be 2 remaining webinars scheduled for June and for July. Before I get started, I'm going to provide some housekeeping details regarding webinar logistics, but I just want to go back and make one additional point. These webinars are focused on evaluation capacity building. However, there will be an additional webinar on the evaluation design implementation, and we'll be talking about that in a little bit more detail shortly. But back to housekeeping. For today's roll call, please enter your state and program name, so PMHCA or MDRBD. So, for example, New Jersey, and then put the program acronym into the chat box located on the left side of the screen and push send. That's going to be our roll call, which we think will be a little more efficient. So, and then at the end of today's presentation, we'll have a question and answer session. Please hold all questions until the end, and then when it comes time for the Q&A, the operator will give us instructions on how to ask questions and also how you can type your question into the chat box. If you have any technical difficulties during the webinar, please use the chat box for assistance. Please type your question into the chat box and push send. I or a JBS IT support account person will assist you as soon as possible. As we mentioned, the operator mentioned, today's meeting is being audio recorded. Once the recording is available, a download link will be provided to all the awardees. So we will now proceed with the presentation. The first part of our discussion today is to provide an update on the MCHB evaluation refinement. As we had, we presented previously and had discussed about the overarching evaluation design, we needed to make some refinements based on feedback and information that was gathered as part of the calls with all of you, which I know I said this previously, but we really enjoyed getting to speak with all of you, and the information you provided was very helpful. Some major components of the evaluation refinement, and I want to explain, is that we're going to roll this out to you in much greater detail, but there's a few things that we're still finalizing but there will be a timeline that I'm going to present at the end here where I talk about that. But the original, the refinement, it's similar to the original design in that it includes an outcome and an impact evaluation. However, we will no longer require awardees to collect disaggregated provider-level information. As you may recall, since you were providing the aggregated information to HRSA, we were hoping to be able to obtain that, the deaggregated or disaggregated provider-level data. And for a variety of reasons, we realized that's not going to be feasible. So that's a big change. And then for the outcome evaluation, as we had mentioned previously, there's a healthcare provider survey that we will be conducting along with a practice level survey. And we're going to then work with you. So the change on that is to have a practice level survey, and then we're going to work with you to determine how the approach for the practice level survey administration, and really kind of the two options that we discussed with some of you on the phone was either we would provide you a link to administer to your providers, or in this case, the practice level information, or we would have you would give us a list of names and we can administer it, or contact information, an email list. So that's something that we'll work with you on individually. In terms of the impact evaluation, that's where I'd say the largest adjustments were made. And what we'll be using is a non-experimental time series design. And for the time series analysis, we will use primary data collection, as I mentioned, the healthcare provider survey, the practice level survey, and the program implementation semi-structured interviews. So those were things that we had shared previously, except for the practice level survey. For the secondary data sources, we've identified several that we would be using, including a couple variables from the National Survey on Children's Health, National Healthcare Surveys, American Community Survey, and possibly some Medicaid data. So those are the types of secondary sources that we would be using. And then, again, just to further highlight that the different activities that we would be doing, we want this more for your records in terms of that you can say, okay, this is what I need to plan for. Probably the most important component on this is that data collection will begin in the spring/summer of 2020. So that's kind of our marker date. So basically a year from now. And what that allows us to do is to obtain the necessary OMB clearance to implement the evaluation activities. So that's, and if you have any questions on this particular slide, we can come back to that at the end. But the only thing that's changed from what you've seen previously is the second, or the third row, the practice level survey piece. And then in terms of for timeline, so for your planning purposes, the next steps with the refinement are that in the June webinar, we'll spend more time on this, providing a more detailed briefing on the evaluation implementation. In September, you'll receive, as part of the webinar in early September, a full data collection plan will be provided. And then upon OMB approval, that the data collection would begin. And so we're anticipating that to be spring of 2020. The one caveat between September and the spring is that if OMB comes back and has any requirements or edits and changes that we have to make, then that could impact what you saw in September. But we'll keep you apprised of that as we have additional webinars with you in the new contract year, so after mid-September. And we'll be scheduling them probably in the coming year a little bit more spread apart, depending on where feedback and where we are in terms of, and you all are in terms of the project needs. So that'll be forthcoming. So if you have any questions on that, please make a note, and then we can come back to that at the end. So now I'm going to, you're going to hear my voice a lot today, so I apologize in advance. But the focus of today's presentation is maybe a little bit of a, I'll say a twist in terms of not necessarily the maybe most expected topic, but there are a couple of things that we have a combination that struck us in our calls with you, but then also some of the experiences that we've had that we thought might be helpful early on that may facilitate some of the implementation of the programs. So, and that's around the branding for not only promotion, but also the actual evaluation activities. And the overarching theme with this can be is that for a relatively small investment can really yield some useful results. One of the things that I like to think about is that evaluation is kind of the first form of outreach. So is there, a lot of times I'll say, for example, on a federal program or different pieces as evaluators, when we're out in the field, we become the face of a particular program. So we're very sensitive to that. And then we also like to work with different agencies and programs to say, is there anything that you're wanting to be able to share with this audience that we're reaching? So it sometimes presents a unique opportunity for some additional communication. But in terms of the branding component is that positive branding here can really trigger a recall message and a salience to a particular program. So when you can really set that up and use that as a promotion component, the literature shows that's really been able to have some positive results. And it also helps to communicate about the program, develop and reinforce stakeholder relationships, and influence behaviors. And we'll go through some examples of how we've been able to apply that in different settings or considerations that we sometimes have. And I think that this becomes particularly salient because of, in some cases, there are multiple programs in a state. Even though they're different audiences, there may be overlap, but separate data is being collected on those, as well as any, we don't know all the data collection, obviously, that you're doing or the instruments, but if there's a way to have a look and feel that connects with some of the promotion pieces, there can be a positive recall related to that. So, what does branding involve? And it really can include a variety of things where it's a program name, an acronym, visual identifiers, the color, a theme, different types of what some of you have, I'd say, a strong brand, and we've been able to look through some of the different websites, and also, but when you're able to kind of hone that language early on and it gets applied, things are put in the same location on materials or products. Again, there's a stronger recall to it, and it's like, oh, that was helpful. Oh, I know how to get that. That's one of these things. It tends to have positive results with that. Wanted to share a couple examples here of something. This was, it's actually a project that we're doing with Blue Cross Blue Shield of South Carolina, the South Carolina Medical Association, and the South Carolina Hospital Association, and it's around the opioid epidemic. And this particular logo that you see here, a lot of these organizations hadn't tended to work together. And then how do we communicate, this was in this case to the provider community, about this and putting, you know, a healthier South Carolina in the middle of this. And so this logo that was created, that, you know, we were able to tie these pieces together, and then throughout the different pieces that we have, there's a look and feel to that. So, and then what we're able to do with the particular logo is that if we don't have all the associations on it, there becomes like an identifier for that, and then we change the colors in different pieces so that there's still a family of colors that are used with that. But, you know, in terms of, and we've done this type of thing across many different types of evaluations, and I'll provide some additional pieces with that. But the thinking about how the program is communicated about, sometimes it's nice to have a, you know, a quick and easy logo or an acronym to be able to refer, but sometimes it just doesn't work, and that's okay. But maybe it's something that you're able to do either, I've seen on some of the state's materials where they've put an acronym in the middle of a map of the state. That's something that can be low cost and effective to say, okay, when I see the state in, let's say, red with this particular acronym, it's a trigger. And then when you're talking about the healthcare provider enrollment, that's, again, the opportunity to let them know they're becoming a part of something. I think that's an important concept. If they're enrolling, then they're going to think, if you're promoting or offering a training, that, oh, that relates to this particular program, and I have access to these behavioral health consultative services, or some of the community collaborations and those types of things. So the more that you can put that into, you know, any type of the branding and the colors, that's going to be helpful. Then when you're asked, you know, there's sometimes we've seen where someone wants to ask, oh, was this training helpful? But they don't remember the training. Oh, I don't remember exactly what it was or how that was connected to a particular piece. In this case, we know from the different reporting requirements that you're going to be doing, there's going to be information that you're looking to gather, or even for your own pieces. So the more that you can do that and then potentially build that in to your instruments, that's going to be helpful down the road. So this goes into some of the examples where it would be helpful if some of the branding was incorporated, because when HRSA requires your programs on the phone here is to submit training data, the types of training materials, numbers of products and publications. You're obviously keeping account of, you know, how many individuals participated in the training, but if there's anything that you're going to be asking about recall, did they receive something, they may not really be aware of that. And so that's where you're able to do that. And then throughout the program, as you're adding maybe additional trainings, again, they're saying, oh, I remember something else. Sometimes you number it. This is the second in the series. This is the third in the series. And that becomes helpful. And then, as I've been kind of linking this together here, is that program branding and formalizing the enrollment process may help with provider follow-up during the evaluation activities. And so, and then, you know, we know that there's also the research that supports that as well, is when they know that there is the recognition that they're a part of a particular program, then we're able to likely get more realistic information in the responses, because the do not recall is what we don't want, or to have false information on that. So here's an example of for a project that we did for the National Institute on Drug Abuse. This is just a little sampling of a particular survey instrument that we had done. And the complexity of this particular study was that there were multiple audiences, target audiences, for a variety of NIDA's resources. And so there were a couple things that we did. One was within the instruments, rather than listing the name of the instrument, we had all thumbnails of all those particular instruments that we were asking about. So for example, for this project, if there was something of maybe you're offering 5 trainings, is there something that you do that indicate, rather than just the name, is there like a 1, 2, 3, 4, 5, and then you're able to know, or something with the resources, that there's the logos on there, and there can be a direct connection to that. And I realize that there's a range of evaluation questions and interests. What we then did, though, with this particular concept, it was available online as well as in print format. For the briefing materials for NIDA, again, we wanted them to remember that there were different audiences, even within NIDA, who had different priorities around. There were about 15 different publications that we were looking at, and whether they were reaching their audiences and how they were being used. And we created a briefing pack that had kind of the puzzle pieces of the target audiences with all these the different publications. So everyone who worked on a publication who would be receiving information would feel a part of this, because their particular products were incorporated into the overall design. And then they knew that there was going to be specific information about it. So there was, I think, a value add. And then we received feedback. It's like, oh yeah, when I saw it was going to be this meeting, I was always going to come to it because it was going to be helpful. So that's the type of thing where there was engagement by the folks at NIDA to actually attend and read the materials and do that. So it was a win-win in terms of how we approached the instrument design, but also the reporting component on that. Here's another particular approach that we took. This was a project was for the Agency for Healthcare Research and Quality. Not sure if how many of you are aware with them, but they, for example, put out the U.S. Preventative Services Task Force guidelines. And we were doing an evaluation with the access and use of some of those. But as part of our thank you, we included this is a little card, and then kind of a promotion for a particular podcast that would be coming. So we were working with ARC to be able to say, hey, something else is coming, not just a thank you and then the closure. So for example, if you have a survey that you're going to be administering, and I know some of you are still planning the needs assessment, maybe it's you're giving them a heads up, hey, this is coming in as part of the thank you, or if it's an online survey, the last screen that they see is what's going to be coming next, or where to go if you have a website, or if you don't have a website, where can they get additional information? So that's right there at the piece. And if you're emailing them anything, that can be incorporated as well. So, those are design elements that come in at the beginning of either data collection effort, as well as then at the end as part of the closeout. In terms of, one of the things that we're very sensitive to is that not everyone has a design department. I'm fortunate here that we've got an award-winning design department, but that may not always be feasible. There are plenty of ways to do something in Microsoft. I want to make you aware of a Canva, which is a free design website, and then obviously if there are resources for a design or communication department. The bottom on the left is actually a thumbnail for a mobile app, and I will say that I don't know if you like it or not, but I'm going to give full disclosure is that I created that in about 5 or 10 minutes when I needed something to be able to show this connection between, for a mobile app. We weren't able to have the design department and our IT folks develop the piece for the mobile app yet of what will end up on Google. This is for a HRSA Challenge grant, but we needed something, and so that there could be a visual identifier for the name of the mobile application and then connecting the mother and baby for clinical settings. And so sometimes something like this will have legs down the road in terms of what the ultimate design will do, but starting with something and being able to even adapt it or adjust it over time, that's something that's feasible. And the images on there that you see, the mother with holding the baby and then the stethoscope, those were free downloads from it that I did in Word. So that's just something that, that as an example. And then obviously there's the nice HRSA one, which was I think clearly done by a design department, and that was something that actually we had done with that. So be able to do that. So that's a couple examples, and I think that was done in Canva. That was done in Canva, and so as an example of something that could be done easily for you. So that's kind of the overarching theme for our discussion today, and I'm going to now introduce our guests who will be speaking first from the state of Missouri, and I'd like to introduce Lane Young-Walker and Megan Corbin, and Melissa Morass. Unfortunately, Wendy L. is under the weather and not able to participate today. So just briefly, Dr. Lane Walker and Megan, yes, she's here, I see, is a child and adolescent psychiatrist who serves as the Chief Medical Director for the Missouri Department of Mental Health and as a Division Chief for the Department of Psychiatry at the University of Missouri School of Medicine. Dr. Young-Walker is the Principal Investigator on the Missouri Child Psychiatry Access Program and has research interests in early childhood and mental health. And then next is Megan Corbin, and she serves as the Central Region Program Manager for the Missouri Child Psychiatry Access Project. And Ms. Corbin, they are housed at the University of Missouri Department of Psychiatry. And last but not least, we have Melissa Morass, and she has a PhD in clinical psychology and is a research and organizational consultant in Missouri. As a research consultant at the Assessment Resource Center, an engagement unit within the University of Missouri's College of Education, Dr. Morass manages a portfolio of applied research and evaluation projects for clients in education, nonprofit organizations, government, and business. Her work as an independent organizational consultant focuses on building capacity, strengthening partnerships, and leveraging resources among local school and communities to facilitate effective, efficient mental health support for all children. So I'd like to now turn it over to Dr. Young-Walker. Thank you. Hi, I guess maybe Dr. Young-Walker isn't able to start right now, but could Megan or Melissa, are you able to begin the presentation?
Yes, absolutely. So hello everyone, we are with the Missouri Child Psychiatry Access Project. We're very excited to be here today to talk a little bit about MoCPAP and some of our branding. So just a little bit of a program overview. Missouri began as a phased implementation project within 2 pilot regions of Missouri. We have the Eastern region, which is located around St. Louis, Missouri, and in July of 2018. And in the Central region, we were able to start here in April of 2019. It looks like Dr. Young-Walker is attempting to talk, so if you want to hop in whenever you are able, please feel free. We have a team of 5 child and adolescent psychiatrists which offer consultation services 1 day a week, Monday through Friday, from 10 a.m. to 6 p.m. To date, we've enrolled 155 primary care providers across these 2 pilot regions and have had over 140 calls. And we will go statewide with this project in October of 2020. So some key project activities. We are a telephonic child psychiatry access line. So we offer telephonic psychiatry consultations to enrolled primary care providers. We offer follow-up care coordination with our program, which allows us to work directly with families and those PCPs to get connected to appropriate behavioral health care resources. Of great importance for our PCPs is that this closes the feedback loop, which has been helpful to have primary care providers enroll into the project whenever they get referrals out to behavioral health care resources. And we also offer 13 educational modules based on Missouri Telehealth Network's Child Psych Echo didactics, and we foster a collaboration with the Missouri Child Psych Echo to encourage providers to participate in both of our programs. Evaluation activities are critical for this program, and we are developing a robust system that allows us to really be scalable and leverage the existing resources that we have as we continue to go statewide. We have a mindset of continuous quality improvement in this project and try and talk data at every meeting. We are also lucky to have a variety of collaborative partners who are able to help this work. HRSA funding is through the Missouri Department of Mental Health, where Dr. Young-Walker is the Chief Medical Director for Children. We have several departments from the University of Missouri, including the Department of Psychiatry, the Assessment Resource Center, Missouri Telehealth Network. Our program management out of the Eastern region comes through Behavioral Health Network of Greater St. Louis. Behavioral Health Response operates our warm line, which takes all the calls for our primary care providers and houses our care coordinator. We're also lucky to have partners with MoHealthNet, which is Missouri's Medicaid program, Missouri Primary Care Association, which serves all the federally qualified health centers here in Missouri, partnership with NAMI St. Louis, and with the Washington University Pediatric and Adolescent Ambulatory Research Consortium, or WUPARC. We will talk more greatly about WUPARC here in a little while. So for us at MoCPAP, branding means consistency. We strive to keep all of our project marketing materials consistent across different mediums. The goal is when a PCP sees a logo or any of our materials, it helps them quickly identify the project and our goals. We relied on PCP experts and steering committees for feedback on materials, which has really helped guide our marketing process. Our logo is very meaningful for Missouri. It represents our state, and you'll see children's arms are outstretched as if they're celebrating. And for us, this represents resiliency in children. We strive to have visual consistency in all of our marketing materials by using similar fonts in all materials, and we always try and use the colors of our logo, navy and red. You will see a mix of more visual documents and documents that are more text-dense that address the different marketing needs for MoCPAP. We will also have some examples of this coming in the slides. It's important to remember consistency in messaging too, because a brand is more than just printed materials. We always use the same presentation structure, which allows for consistent messaging across both of the regions where we've implemented and with different groups that we present to. We have found that it has been helpful to have a resource email account that identifies our name to providers. We promote the use of this resource email to ensure there's a connection to the project and not just one person who might be a staff. This makes it easy for providers to contact us with any questions that they might have. So now let's see some examples of some marketing materials from OCPAP. And I'd like to say that most of these materials have been created in Canva. This document is what we call the structure of a MOCPAP consultation. It describes to PCPs how to use the service in a more visual algorithm. And this has all the information that that they need to be able to participate in any services, along with our phone number. We have been finding success in using this marketing material at practice visits or when promoting MOCPAP to different stakeholders. Here's an example of something that is more text dense. As we implemented in the central region, our primary care providers asked how they could know who the child and adolescent psychiatrists who consulted on this project were and what their research interests are. As you can see, it still has a lot more text, but it's still branded as MOCPAP with our logo and the same colors at the top. Here you'll note some pocket cards. This document fits within a lab coat and has information about MOCPAP on the back. We originally wanted this document to be a magnet which could be placed in exam rooms. However, we were lucky to have our PCP experts who told us how these pocket cards might be more effective than exam room magnets because they're not allowed in exam rooms per infection protocols. So this is a really important lesson learned. This is an example of a pocket card with our educational resources that covers all the common diagnoses and topics available through MOCPAP. We originally designed these as reminders for our consulting child and adolescent psychiatrists to direct providers to our educational resources so that we're promoting more than one project service whenever a provider calls in. So we all know that stories can be a really effective way to engage and show the impact of a program. Our steering committees and collaborative partners always want stories about the project, and during presentations with providers, key stakeholders, and those who can help sustain this project, we always share stories from PCPs who have been touched by MOCPAP. Here are some examples that we use in our presentations. This first example comes from an initial focus group done in our central region. These helped us better understand the PCP's daily struggles in supporting children who had behavioral health needs. And at the beginning of all of our presentations, we talk about this to help validate some of the struggles that PCPs can experience whenever we're at practice visits. The second example comes from a post-call satisfaction survey from a primary care provider based on their consultation experience. We think it adds credibility to the service and shows the impact from other providers that this service can have. You'll also note we still brand this information. We have bolded important text and colored it into both navy and red. Through the enrollment of PCPs, we thought it would be helpful to discuss some of our enrollment strategies that have been successful. Woo Park is a collaborative partner in our Eastern region, and they have a network of over 87 pediatric PCPs who are supported by the Washington University School of Medicine. Through this organization, providers were already engaged in improving their skills in treating mental health needs of pediatric patients. And since they already had existing relationships with these providers, and MOCPAP fit so nicely with what they were working on, this group successfully led enrollment efforts in the Eastern region and allowed us to double our recruitment goals for the year. We've also found that provider presentations can be really effective for the enrollment of providers. However, there's often difficulty in getting in front of these very same providers. We found that engaging with a practice gatekeeper can be really critical. This can sometimes be an office manager or a physician champion who can connect you to the right person to get on an agenda. We have accepted almost all opportunities to present to different audiences about MOCPAP. This is part of a strategy to broadly figure out how we can engage PCPs through different groups, because you never know where you might find a champion. For example, in NAMI St. Louis, asked us to present to family members involved in a workshop of theirs. NAMI sent out action alerts to these families, encouraging them to talk to their PCP about MoCPAP if they had children experiencing behavioral health needs. Also, we always end our presentation with a call to action focused on the enrollment of PCPs in a way that makes sense for that audience. We have found that some providers might even enroll when we're in the room. We have started engaging statewide organizations to support the enrollment of PCPs as MoCPAP goes statewide in October of 2020. State leaders from the Missouri Department of Mental Health, MoHealthNet, Missouri Primary Care Association have all promoted MoCPAP to their providers and encouraged them to enroll. We continue to strategize with Missouri Telehealth Network's Child Psych Echo to figure out how to collaboratively support enrollment in both of our programs. Some of these strategies describe how we both use a top-down and bottom-up approach to enroll primary care providers. And with that, I'm going to invite Melissa Mares to join us.
Wonderful. Thank you so much, Megan, and hello, everyone. My name is Melissa Mares, and I am the MoCPAP project evaluator. And I'm excited to be here today to talk to you a little bit more about some of the strategies we've used for marketing and promotion and some other factors of our program. So marketing materials, all of our marketing materials drive providers to the MoCPAP website, which is housed under the University of Missouri School of Medicine. We thought it was important to the project that the website not be independent, but rather be connected to the academic medical institution of MU. This partnership has enabled all website costs to be at no cost, ensures credibility, and allows providers to access and use our resources freely. Enrollment of providers is done through the website, which feeds into our REDCap database. Here you can see some examples of what our website looks like. As you can see, it's tied to the University of Missouri School of Medicine. Near the top of the website, there is a button for enrollment. Oops, there it is. And so you can see the Enroll Now button. And that takes you to provider enrollment. So to use project services, PCPs are required to enroll in the project. Primarily, this is done online through our REDCap database. After selecting the Enroll Now button, they are taken to a provider agreement screen, which describes all of MoCPAP's services and lays out expectations for participating and benefits to participating. Also, we discuss what MoCPAP cannot do, and we found that to be particularly important. We appreciate the support of established programs when putting this language together. We feel like we've been proactive in reaching out to other projects in different states to learn from them, and we're really proud of our progress given that we have will only be a year old this coming July. We also have a brochure, and this brochure shares information about MoCPAP, and we do allow enrollment by paper as well as through an enrollment insert in brochures. This is certainly not our preferred way of gathering data, since we have to then send an alternative baseline survey. However, we do know that some providers prefer paper and fax to websites, and we don't want to impede enrollment in the program. After enrolling in MoCPAP, providers receive a welcome letter from our REDCap system, which also includes a user guide for all services. To the extent possible, we use data collected in the REDCap form to personalize those communications, so doing things like addressing them by name and using their preferred affiliation. We also use the website to promote and describe our educational opportunities. So all of our resources are freely available on our website, and they link to Box, which is an online storage system. And these resources are organized in folders around each diagnosis. We originally had a login feature to the website. However, we realized this created a barrier for PCPs to access resources. And this has added some complexity in reporting the number of providers who have utilized the website, but we found that using Google Analytics has been a good proxy so that we can see how many times these educational resources were accessed. We also send out bi-monthly newsletters which often reference our educational resources as well. And our CAPs, our child and adolescent psychiatrists who consult with the PCPs, also promote these resources. So this is an example of what the educational resources look like when you go to our website. Just as a reminder, these resources are free, and so if you're interested in seeing what these are, feel free to check out our website. And this is one example of our newsletters that we send out. In terms of the website, all PCPs have to do is click on the links. So I'll go back, click on these links, and they're instantly allowed into that folder. And the folder includes AACAP and AAP practice parameters and recommendations, medication algorithms, and evidence-based screening tools they can use in their practices. So we would like to thank HRSA and JBS for the opportunity to present on this webinar. We're very proud of our program and are excited to learn more from all of you in terms of what you're doing in your states. Again, there's our Most CPAP contact information and our website. And certainly if you're interested in subscribing to our newsletter, then please email us. Thank you very much.
And we're at the very end, but I just want to see, can you now hear me? It's Lane.
We can.
I'm sorry. I'm very sorry. But I'm Lane Young-Walker, and I am a child and adolescent psychiatrist. Was very excited about thinking about this type of a program for Missouri, and the ultimate goal is to take it statewide.
Thank you, Dr. Young-Walker, as well. But is there anything else that you'd like to add to what your colleagues shared? We want to just make sure you have an opportunity to add to anything that they've said, given the technical challenges we had.
No, I think that Megan did a wonderful job, and they were Dr. Young-Walker challenges because I obviously didn't sign in the right way, which is why I could see everything, but you couldn't hear me. So I think she did a really great job. Megan, thanks for jumping in when I couldn't, and Melissa too.
Thank you. And I just, before we move on to Kansas' presentation, I just want to tie one piece into our webinar number one. The pieces that I thought that both Megan and Melissa were talking about really grounded, if you recall from our first webinar, the triangle where we had the connections between the provider and the practice, the training and the encounter, that triangle there. This presentation, I feel like it really starts to operationalize that, of how that training component and that enrollment that John Strauss was talking about, and how those pieces, and so here you see the like real world examples of how that's been triangulated across their program. So thank you so much for your presentation. And now we're going to move on to two individuals from Kansas who are going to be making the presentation. First is Nina Bishman, and she is a research project coordinator at KU CPPR. She provides program management and coordination for the Kansas Connecting Communities Initiative. Nina previously worked as a director for the nonprofit organization Boys and Girls Club of Lawrence, Kansas. She has 5 years of experience in program and curriculum development, management, and data reporting through her work in direct services with children and families. Her degrees of study in human biology and psychology speak of her passion for studying and understanding the human mind and behavioral health issues within her community. And co-presenting with her today is Shauna Carroll Chapman, and she is the co-principal investigator for KCC and is serving as the interim data manager / evaluator. She is an assistant director of research and evaluation at KU CPPR and conducts quantitative, qualitative, and mixed methods research, and has led or participated in the development and implementation of and evaluation of multiple public health and health-related policy programs and initiatives. In this work, she has conducted systematic literature reviews, facilitated focus groups for a wide range of individuals, conducted interviews, developed and administered surveys, and related data collection instruments, and analyzed quantitative, qualitative, and mixed methods data, including data from health records. Her past research focused on women's health with an emphasis on disparities in populations such as women with disabilities and those living in poverty. I'd like to welcome Nina and Shauna at this point. Thank you.
Thank you for having us. We're excited to be here today to talk about the Kansas Connecting Communities project. Nina and I are going to talk to you a little bit about what the project looks like and then some of the branding that we're doing and some of our upcoming activities. So just to give you an overarching idea of what we are doing, it is a collaborative initiative between multiple partners across the state. So we are funded out of our Kansas Department of Health and Environment, so our state health department, Title V Maternal and Child Health Program, which is in the Bureau of Family Health. So they are bringing together multiple partners that we'll go through in later slides to help build a system in Kansas to make sure that women are getting the screening, treatment, and referral to treatment that they need for depression, anxiety, and substance use. If you look on the right, just talking a little bit about our branding, this is what we have come up with to this point that demonstrates the project. And what we have done with this, and you'll see our Title V brand in just a couple of seconds. But we have, as I think was referenced in an earlier slide, tied this into the same color palette as that. And we are really implementing our programs through our Title V work, so it is very integrated across projects. I'm going to go through and probably be a little bit redundant as I talk, because I want to talk a little bit about how we are doing a phased approach in Southeast Kansas, and then we are going to go ahead and launch statewide. But our overarching vision is this is part of the work that Title V does, and so this is integrated into all Title V programming. So we are making this available to all providers, service providers across the state, and that includes medical providers, social service providers, home visitors, anyone who would be working with a perinatal woman, but especially within our own program and grantees, this is who we are and what we do. So we're making sure that this system is in place and is well advertised and people know about it. But we're not making it so much a separate program as we are integrating it into Title V as a whole, which we also think is key to sustainability. So as I said, we are implementing a phased approach. So we're starting in the southeast corner of our state, and you can see the 10 counties there. I don't know if anyone knows a lot about Kansas, but this does tend to be the most impoverished part of Kansas. There's a lot of need in this area. We have identified 3 communities to start with in year 1, and then we will pick another 3 communities next year, and then another, or the final 4 communities in year 3. In year 4, we're going to do a soft launch across the state where we target those communities that have expressed a lot of interest and have been coming to some of the events that we are having already. And then in year 5, we hope to do a full statewide launch. So I went ahead and listed our goals, and I want to talk a little bit about what we're doing within each of those. So the first one is to develop and disseminate trainings and integration toolkits around the Edinburgh, which is our postnatal depression tool that we're using. It's actually perinatal, so we're using it prenatally and postnatally. And it also does measure anxiety. And then screening, brief intervention, and referral to treatment. And we have, we're recommending use of the 5Ps Plus, although we have talked a lot about other tools as well. So if the provider is using a different tool, that's okay. But our current recommendations, particularly for our expert toolkit, will be the 5Ps Plus. We do have a mental health integration toolkit that is already available. I don't know if when these slides are disseminated, you'll be able to click on that. It is a link. If not, you can reach out, and I'm happy to share that with you. The toolkit is posted in a couple of different ways, so it can be downloaded as a full PDF document. It's also available in pieces by topic area, so if providers want to come in and they're just looking for a specific resource, they can pop in and get that resource, or they can download it as a booklet and use it in that format. The expert toolkit we're working on right now, we will have that done by July 23rd when we're having a regional event that I'm going to talk a little bit about in a minute. But that is the timeline that we're currently on. It will be housed with a mental health integration toolkit. That
site, if you do go and are able to click on the link, is not its permanent home just yet. The KDHE communications team is working on a new website platform for those toolkits, and they will be housed there. But as I was talking with our integration into Title V, that is the home of all of our integration toolkits. The Maternal and Child Health, Bureau of Family Health has quite a few that are hosted through there. So it's kind of like a one-time repository. We also have some advisory councils. They actually were previously work groups before we received the funding who are helping with development of these toolkits. We've transitioned them into our advisory councils, and they consist of providers from across the state. We have one individual with lived experience on the mental health advisory council, and we're working on that on the substance use advisory council as well. And then we are working on a regional and virtual trainings, which we'll talk about in just a second. So our second goal is to utilize telehealth and or community resources to provide real-time psychiatric consultation and care coordination. Our program is a little bit different. We are very much a community-based program. So what we are doing is utilizing a unique resource called IRIS. It's an integrated referral system. That's what IRIS stands for, Integrated Referral Information System. IRIS actually is developed within the community. Community partners come together. They determine how it works, what a referral form looks like, how quickly referrals need to be met. There's a lot of information, and for those who are interested, I can share websites and little demos that can show how IRIS works. It's not a database. It really is. You go in, you can see all of the providers in your community, the different types of services they can provide. You can actually go ahead and make a referral for a specific individual, type notes to the person you're referring to, provide all kinds of information about what you need and what that person needs, and then actually track how the referral was picked up, what happens to it, if the person gets services, if they don't get services. So IRIS is this very unique system that allows us to build community systems within individual communities across Kansas. We are working with the Central Kansas Foundation for substance use treatment when substance use treatment is not available, particularly in a rural community. And then we are working with our community mental health centers, which are the safety net mental health services in Kansas. So they are required by state mandate to actually provide services to anyone who walks through the door, and they provide both mental health and substance use treatment. So goal 3 is to develop linkages and care coordination across providers, and that's what I was talking about, utilizing IRIS. So we're really building this community system, and we're trying to get these different community partners to connect to one another utilizing this internet technology. Develop and implement peer-to-peer support training. That is a piece that we have through Wichita State University. So we actually do have a database of all the peer support groups across the state. We are integrating, developing those, and hosting those and housing those within a lot of the training that we're doing, and then connect service providers to a statewide online database. And our database is actually IRIS, so it's so much more than that, but all of the different providers are housed within that because they all have a page that they can go to and make and pick up referrals. So goal 4 is to provide services through telehealth or community providers following initial consultation. So, and we're working on that on the evaluation side. We're actually conducting an environmental scan where we're working with the providers in Southeast Kansas to find out what they are currently doing, and then we're planning to monitor that over time to see how things change. We are working on developing those protocols because, again, when we're working directly with providers in the community, what we find is the biggest thing that we need to have in place are the protocols for them so they understand what to use when and how to use it together so they're reaching each other. IRIS is also great for that because we have community conversations where we can see real-time data. We bring providers together and can talk about what's working and what's not working, who's getting referrals, who's not getting referrals, how that's going. And then we are providing services through telehealth or community mental health care providers. And again, we are a rural state. We don't always have the providers that we need in every community, and that's where the telehealth piece comes in. But they are also a component in IRIS. So the way that that works is we have different IRIS communities across the state. Central Kansas Foundation is actually in each of them.
So if I am in one of our pilot communities with that county and I want to refer to them, I can go in and refer and have that conversation through IRIS for Lebec County. However, Central Kansas Foundation is also in Fort Geary County, so if someone in Geary County needs to make that referral, they would do it. It's a different module. Geary County and Lebec County cannot see each other, so it's a separate community-based referral system. Goal 5 is enhanced alignment of state and local partnerships. And so, as I mentioned, these are the different partners who are working together to build this system in Kansas. Kansas Department of Health and Environment is the grantee. Central Kansas Foundation is providing telehealth and consultation for substance use and addiction treatment. Wichita State University is really working on the community support piece, making sure that communities have the services and supports that they need to implement community support groups. The maternal and child health is actually our Title V agency within KDHE. Project ECHO, we are utilizing virtual training to assist with screening, treatment, and referral. So we have a couple of wonderful trainers who are working together. And one of the things that we discovered pretty early on as we were going through and talking about this was when we originally had conceptualized the project, we had talked about these as kind of two separate things. We have two separate toolkits, right? Maternal depression, anxiety, and then substance use. And we realized pretty quickly on that we needed to integrate these so that we are presenting them as one unified message to providers across the state. And so our trainers are working together to do that through a curriculum for both our regional event and through our Project Echoes. And then we've actually talked a little bit about some kind of an additional toolkit working on that integrated approach. And then the last partner on the slide would be us, the Center for Public Partnerships and Research, and we provide the backbone support and evaluation for the project. So this is really a huge part, as I had mentioned, of Title V in Kansas. We are really working very hard to go ahead and break down traditional systems of public health. We're going away from a very program-specific sort of business-as-usual individual impact model, and we are really trying to build systems where all partners are integrated and combining efforts so that we can leverage our funds, we can make sure that we're reaching everyone in the community, and we're all working together. CQI is a huge part of this, which is one of the roles that we play here at CPPR. So IRIS, as I mentioned, is wonderful because you can continually analyze the data and see how the referral process is going, see who's reaching out to who, and what's working. But we believe that this is the way that we can have the biggest impact on our communities. And this project in particular, depression and anxiety screening and substance use screening, is something that we have in almost everything that we do, whether it's an MCH-specific program, whether it's our Early Childhood Comprehensive Systems grant, whether it's one of our Healthy Start grantees, whether it is a program that we have for teen moms. These are the things that we need to be doing, have all of our providers doing. So this is part of what we really push here. So this is, as I had mentioned, I was going to pull up some of our branding for Title V. This is our wheel from our 5-year state action plan. And of course, we're working on this right now. So this is going to change a little bit here in the next few months. But you can see it's the same color palette. And I'm not going to talk too much about our priorities, but just to emphasize that point again, what we're doing on KCC fits within almost every single one of the priorities that we have identified through our 5-year state action plan. So it is a pivotal part of the work that we're doing. This is our MCH website. So on the previous slide, we had listed a KDHE website. KDHE has a website that you can go to, and you can find all of the different programs through the Kansas Department of Health and Environment. It's very much controlled by KDHE and that branding. So we also have a specific MCH website that has our branding. It has upcoming events. It has postings for our advisory council. It has, when we want to get public comment on our Title V block grant application, we'll go ahead and post it there. It has the activities that are going on and should soon have links to toolkits and things that we're talking about today. And then, of course, we also have a Facebook page. And again, you can see that carry-on of the branding. And this is where we also post events, things that are upcoming, and resources for individuals so that they can see what Kansas MCH is doing and where they can find resources.
So in terms of our evaluation, we do have 3 overarching components that we're looking at. It's the local and statewide capacity building. Like I said, we're trying to build systems in communities. So this is an integrated part of everyone's work, and it's sustainable. It's just how things going forward. And that is around the maternal behavioral and mental health screening, referral, and engagement, so making sure providers are engaged both with IRIS. And then DAISY is our data collection system that we use to store and house our data, and we can talk a little bit more about that if anyone wants to. But I really think the big piece for what we're talking about today is IRIS and how the community partners interlink together through that system and how that links into Title V. And then stakeholder response to telehealth and peer support linkages and referral system. And all of these have data on the back end that we can take a look at and see how things are going. So we have some upcoming events that we haven't had a chance to design a lot of materials for. We did do a presentation at the Governor's Public Health Conference. That really was the first opportunity we had to integrate the SBIRT and MDS training. That was in April of 2019. And that really was our first opportunity to see our trainers work together as they were sharing the same message about getting this integrated into practice, and it was great. It was standing room only, so it was a well-attended and really good event. We are planning our regional event in Southeast Kansas, and it says July or August, but that actually will be July 23rd. We are hosting that at one of the local universities. And we are actually inviting individuals from around the state, but we're really concentrating on folks in Southeast Kansas to come and learn about the importance of SBIRT and MDS screening, treatment, and referral. We're really trying to get them to understand the importance of why they want to do this, also making sure that our SBIRT is reimbursable in Kansas if you go through a specific training through one of our state agencies, so making sure that they've done that and have access to that, and then really talking a lot about our echoes, which will be upcoming in September. So, and the KDADS training that I had mentioned, the web training to get reimbursed is the next on the slide. So we just want to make sure everybody is going through that, and we're tracking to see who is taking that and who is not. And then we will have 4 echo sessions integrating the SBIRT and MDS training in September. And just a little bit about some of the ways that we do outreach and work. Since we are working in the community and we've really integrated into Title V, we have a very boots-on-the-ground approach, going into communities and working directly with community providers. Mina attends community coalition meetings in all of our pilot communities. She's presented at all of them to the providers, talking about what KCC is, what's upcoming, what it can do for them, and making sure that they know us, who we are, and how they can reach out to us if they have questions or would like more information. We also work very heavily, as I mentioned, our advisory council. They are providers across the state, so they're an amazing resource to get information out and also talk about what providers need in different communities that we can come in and then provide support around. We have many community champions who are hungry for the information, so of course we disseminate information through them, let them know, and then let them share that among their networks. And that's actually one of the best ways that we have had to, in all of our programs, to get information out. I mentioned the IRIS community conversations. We do those quarterly, so we bring all of the partners together, sit in a room, and talk about what's working and what's not working, and what kind of modifications we might need to do. And then we do have the regional and virtual training events that are coming up in the near future. And that is all that we have, unless anyone has any questions.
Well, thank you, Shauna. And this is excellent. One of the pieces that I want to highlight from their presentation is that I think this is an excellent example of where they really wanted to fit in. They didn't necessarily want all the distinction because of the strategic decision to be part of the Title V program within the state. So it was very important to be fully integrated into that, and you can see from the presentation how they approach that with the branding and all the different materials. So it's a different twist and approach to that, but as you can see, effective, and then leveraging something like IRIS, an existing system that's being used across different programs and then being able to use that for their data collection and management and information resources and all those pieces. So I think you've got two different examples of the use of branding and the communication components and linking that with the evaluation and data management for your consideration. So at this point, I'd like to just open it up for questions and answers. And I'm going to turn it over to the operator so she can give instructions.
Thank you. We will now begin the question and answer session. If you would like to ask a question, please press *1 and record your first and last name clearly when prompted. Your name is required to introduce your question. To withdraw your question, you may press *2. Once again, if you would like to ask a question, please press *1. One moment, please, for our first question.
And I also just wanted to open it up to the group that you can also put a question into the chat box, and we'll work through those as well. While we're waiting on any questions that we have, also wanted to just highlight and share is that a number of, as I mentioned earlier, a number of the states that you have different, maybe a web page or come up with an acronym. I remember talking with New Jersey and them having a two websites. One was a website about the program, but then once a provider was enrolled, they were able to have a separate website that became something that they were able to, their providers had a login and then accessed resources specific to providers enrolled in the program. And so that was another type of approach to be able to look at that. And then in terms of Florida, that they have another website also that they were able to use and use that across the different programs and be able to use that. So there are different pieces. Montana has developed an infographic to help with the promotion, and we know that there are a lot of different activities that your states are engaged in, and how important and helpful that is in terms of the overall program implementation. And I'll just turn it to the operator. Are there any questions at this point?
There are no questions in queue at this time.
Okay. I see that one was submitted by Kathy Karstein asking that after the baseline survey on enrollment for Missouri, what data collection do enrolled providers do for the project? Frequency of data collection and reporting. So if I could turn that over to either Dr. Young-Walker, Megan, or Melissa.
Hi everyone, this is Melissa and I can chime in on this. So in terms of data collection after the baseline survey, we survey our PCPs after every call, so they receive a brief satisfaction survey either through REDCap if it's a consultation call with the child and adolescent psychiatrist only, and then there's a separate mechanism if they do choose to use the linkage and referral. Right now we're working on coordinating those two systems because we are actually leveraging two different data collection systems, so we're trying to streamline that and make sure that that all makes sense. So they get those satisfaction surveys, and then we also survey them quarterly, and that is the same survey that they complete at baseline, along with some satisfaction surveys and also some items that ask them to indicate what other resources that they've accessed through most CPAP. More recently, we've actually conducted some focus groups that we found very informative, and so we conducted two focus groups with two different groups of PCPs to ask, and this was actually in the central region, so this was before we opened the lines in our central region, and asked them about what would be useful, kind of gave them some ideas of what most CPAP is and asked them for feedback. And so we've already started incorporating some of those data. And so I think that's all, and Megan, correct me if I'm wrong, but those are the data we collect from our PCPs. Oh, and then so quarterly surveys, and then the quarterly survey that falls kind of on the annual survey timeline, we use as the annual survey.
Thank you. Megan, anything to add to that?
No, Melissa did a fabulous job.
Thanks, Megan.
Kathy, please, if you have any follow-up questions, don't hesitate to jump in, or anybody else. Krista, I just wanted to see, thank you for your comment in terms of that I listened correctly with New Jersey. Would you mind just talking a little bit about why New Jersey made the decision to make that quote-unquote hidden web page, as you referred to it? I think you have to press *0 to be able to open your microphone to respond to that.
Please press *1 to ask a question. Again, if you would like to ask a question, please press *1.
Operator, I think we wanted Krista to be able to just speak to the group. Is that an option for her to do?
If Krista could press *0, please.
See, Krista is typing, so we'll wait a second for that to pop up. Oh, she tried *0, but it doesn't seem to be working. Is there any other options, operator, in terms of what could be done?
She could press *1 and I could open her line through the queue.
Okay, would you like to do that, Krista? And operator, while maybe just interrupt me, I'll just make a couple additional comments. Just wanted to see if there were any questions or comments from HRSA at this point. Okay, well, unfortunately, it seems like we've got some technical challenges, but maybe we can work with Krista and have a follow-up response that we can send to everybody electronically, so we appreciate that. And operator, are there any other questions in queue at this point?
There are no further questions in queue.
Okay, and let's see, I don't know if Lauren, if you were still able to be on the call, if there's anything else that you wanted to add.
This is Lauren. I am on the call. Nothing to add, but really thank you all so much for sharing your experiences. It's so impressive with this group how willing you are to give and to share and learn from one another. So thank you so much.
Thank you. And just want to thank everyone for participating today and for our presenters. Really appreciate the time and effort that went into this and all that you shared. And we look forward to our call in June with all of you. So thank you so much. Oh, and I see Krista just put a message in there. So, and I think Alexander Murphy, okay, there you go. So what Krista wrote was our hidden web page is used for those providers that register for our Pediatric Psychiatric Collaborative. And we did this so that info on access to psychiatry hubs, screening tools, and other pertinent documents is made available only to those registered for the PPC. So thank you so much. So that was a decision of how to deliver that information to those, and that they're very much part of that program then within New Jersey. And I know New Jersey was also expanding to telehealth in terms of the number of providers, aiming to be over 1,000 additional providers in more rural areas. So there are some advantages in terms of being able to disseminate that information to a broader audience. And Krista just responded as well. So we just appreciate, again, everyone's participation, and we look forward to being in touch soon. So thank you so much. Everyone back 7 minutes in their day. And if anyone from HRSA would like to remain on the call, we'll have a little debrief after. So thank you.
This now concludes